There you have to be careful, and you may have to lyse those patients longer, and then you may or may not get a good response to that at that point. And self-expanding nitinol stents, I say 10 to 14 over there, but you can go up to 16, even 20, depending on the native portal vein size. And I'm going to go to two cases. The first one is a 51-year-old female on transplant list, large varices, massive splenomegaly, thrombocytopenia, platelets are 22, and then she's been bleeding on and off. So she's initially referred for splenic reduction to correct the platelets because they were also hoping to transplant her sooner than later and wanted to get the platelet issue out of the way. So we did a splenic artery embolization. At that time, we did a proximal splenic artery embolization. This was like probably my first year at Rush. So we didn't have very good communication with our hepatologists at the point. They were concerned about distal splenic artery embolizations. Now we do all of our splenic artery embolizations distally. But these were coiled. As soon as we did it, this works as well, but it works temporarily. Most of these patients, their platelets kind of go down within a year or so. Again, at least in my experience. So this patient's platelet improved from 22 to 101, but on day 10, she presented with abdominal pain. As you can all guess, when you embolize the spleen, you know, those larger vessels, stagnant flow, they lead to thrombosis, and the patient presented with a portal vein thrombosis. So we went ahead and accessed the portal vein, planted tips, and eventually occlusion of the shunt too, because you can't have the tips and the shunt together at the same time, especially a very large shunt, which will compete and cause rethrombosis. We had that discussion with the hepatology team, and then they didn't want to have it both done at the same time again, so we did the tips, got into the portal vein, which is a little bit more challenging, but you know pretty much when you're in the portal vein, and eventually placed the tips. You can see the flow is kind of hepatofugal and going all the way through the shunt into the renal, and not much coming towards the liver. A small tips placed, angiojet used, cleaned up the clot, looked okay at the end, and this is our angiojet device again. Fresh clot, it'll always work. And this is our final picture. And the gradient was reasonable, so we stopped and we moved on, planning to bring the patient back next week for the BRTO part. So when the patient presented 1 week later, everything thrombosed again, the tips and the portal vein, part of the portal vein, as you can see on that second picture up. So we used angiojet again, cleaned it up, and then this time though, we went ahead and kind of do it like a backdoor, front door approach that Dr. Saad always talks. Since we had tips access, we found the shunt from above and coiled it from above, put a balloon from below and sclerosed it. And on the table, we were able to thrombose this kind of massive shunt, and the flow in the tips was significantly better. We also further dilated the tips, obviously, to get better flow. And this actually did it. You know, once you find the balance, the gradient was still 11, but that was a good gradient for that patient. Follow-up showed that the tips was patent, and patient remains stable, received transplant 2 years later with no issues in between. So when patients are not treated properly, as you know, Vijay showed the case too, people tell me that anticoagulation works, you never have a problem in these patients. But these patients, in our experience, at least the ones that we see, always come back with a problem if you don't treat their acute portal vein properly in the long term. It may be 3 months, 3 years, whatever. You're setting them up for kind of failure. And then they turn into chronic portal vein thrombosis patients, and then some of them will develop ascites, intermittent bleeding, progressive thrombosis, and related symptoms. So this is a patient similar to that, presented with acute portal vein thrombosis. They put them on anticoagulation. Anticoagulation doesn't do the job, and they turn into like a lifelong mess. Anatomy doesn't appear to be amenable for tips, even though they wanted the tips. So this is the CT scan. You can see it's a complete cavernous transformation. The splenic vein is thrombosed, and part of the mesenteric vein as well as the portal vein is also thrombosed. Huge spleen. And this patient was embolized once outside, and then we did a transsplenic access and embolization of some of the shunts that we thought were bleeding inside the stomach area. And after that, we decided to decompress this with a splenorenal shunt. And this is our splenic angiogram. As you can see, it's going nowhere but to the collaterals and shunts, and very little through a tiny little connection between the splenic and the renal vein. And so groin access was obtained, and a sheet placed into the draining vein into the renal vein, together with a splenic access that was percutaneously. And using an RF wire and a snare in the renal vein branch, we steered our RF wire through the soft tissues and got into the snare. And after getting into the snare, pretty much all you do is you pull it out, you kind of slightly dilate the tract, put a 10 French sheet, and then put a covered stent graft in there. And this is after deployment of the covered wire-bound stent graft, 11 millimeter. And this is our after angioplasty final result. And you can see on the CT scans that all those collaterals, everything disappeared, mostly thrombosed on the follow-up CT scan. This patient's bleeding stopped completely. And then I think this also got a transplant a few years later with no issues. And this is the patency of the splenorenal shunt about a year after. So to treat the acute thrombosis early after initial anticoagulation attempt, we always check them if the thrombus has been released. Not rely on the clinical picture only, because that thrombus can lead to further problems down the road. They're easier to treat in the acute phase, and if you don't treat them in the acute phase, they turn into chronic, and it becomes more complex, and patients usually suffer more, and the options become relatively less limited for these patients. Thank you very much.
Okay, thank you, Dr. Arslan, for this nice talk. Is there any question from the audience or the chairpersons? Okay, so we don't see. Oh, okay, so we can move to next lecture. Thank you. Yeah, thank you very much. We move to the other lecture now. Going to